everyone. I'm Dr. Sunita Mohan, the co-instructor for this IC. So our IC is about diabetic retinopathy, bedside to bench to bedside. So basically this IC is about how we can use the information that we have collected at the bedside, that is at the patient's end or at the screening end, and then use it in the lab or analyze it and again use those information for the betterment of the subjects back onto the community. So I'll just briefly mention about the speakers that we are having. So we have a keynote speaker, Dr. Martin Zinkernager. So he'll be speaking about gut microbiome and association with retinal diseases. This would be followed by a session, followed by a note from me, which would be about an update on the epidemiology. This would be followed by Dr. Kumar Manikvel, who would be speaking about the genetics of diabetic retinopathy, followed by Dr. Rajkumar, who would be speaking about microbiology of DR, which is also one of the components that we need to understand, followed by Dr. Shobha, who would be speaking about the linking between the basic sciences and the imaging, followed by Dr. Rajiv Raman, who will be speaking about the AI, which is an upcoming and still in infancy, but an upcoming topic in diabetic retinopathy, followed by Dr. Kim, who would be speaking on the neo vistas in imaging. So we begin the session with, I would invite Dr. Martin Zinker-Nagel to speak on the gut microbiome and association with retinal diseases. May I request all the speakers to stick to time? That would be 8 minutes of the talk and 2 minutes of the interaction with the audience. So after every talk, we will have the interaction with the audience. Thank you.
Thank you very much for the kind introduction. Dear committee, dear co-instructor, thanks for inviting me to this wonderful meeting. So I'm going to talk about the gut microbiome and associations with retinal diseases. These are my conflict of interests. Now, the microbiome has received a lot of attention in the recent years with it making headlines in many prestigious journals. And it has found its way into ophthalmology. So what's the gut microbiome? It's basically the collective of microbes residing in our guts. Each of us has up to 100 trillion bacteria in our guts. The body contains roughly as many bacteria as human cells. And there's over 10,000 different bacterial species identified. So each of us has a tremendous amount of bacteria in our gut, and they're just normal. So what are these bacteria actually doing? They're digesting our food, and they have been implicated in playing a role in several diseases, such as inflammatory diseases, such as neurodegeneration or AMD, but also in metabolic diseases, such as atherosclerosis and diabetes. And what you can see here is that if you have a change in your composition of the microbes in your gut, this will lead to dysbiosis and altered levels of inflammation and inflammatory mediators, ultimately leading to diseases in the central nervous system, but also in your metabolism. And this is a graph how this is working. So you have basically the microbiome in your gut, and all these bacteria digest your food, your sugar, your fats, and helps you to uptake these components into your bloodstream. Now, the food also alters the composition of the gut microbiome. Now, we know that there is a link between retinal or macular diseases and nutrition. We know that from the ARID studies. We know that there's a link between macular diseases and complement activation, genetics. And I'm sure we're going to hear a lot about that in the following talks. And we have recently shown that there is a link between macular disease, especially neovascular AMD, with the gut composition or the gut microbiome. Now, we looked at a relatively small cohort of patients with neovascular AMD and compared the gut composition with healthy controls. This is the bioinformatics pipeline we used. So we did a whole DNA sequencing with the stool probes of these patients and controls, and we did analysis to analyze the composition of the microbes residing in the guts of these individuals. This is the demographics, so fairly balanced groups. We also did genetics, where we saw that certain risk single nucleotide polymorphisms were increased in our patients with neovascular AMD, in keeping with the literature. And then we looked at the gut microbiome, and you can see here these two groups. So basically, we have two groups with one healthy group, one group with AMD, and you can see here that certain microbes were more abundant in patients with neovascular AMD, such as Firmicutes were higher in patients with neovascular AMD compared to controls. On the other hand, we found certain bacterial species, such as Bacteroides, which had a lower abundance in patients with AMD compared to healthy control groups. We also found that certain bacterial species were upregulated, such as Oscillobacter, and as I mentioned before, Firmicutes were upregulated in patients with neovascular AMD. Now, this is a session about diabetes, and there's also a lot of research going on looking at the gut microbiome in patients with diabetes. And it is thought that the gut microbiome changes, or alterations in the gut microbiome composition changes the way we digest the food and the way we deal with the digested food. And it's thought that if we have a dysbiosis in the gut microbiome, this predisposes to diabetes mellitus. And these are two just recent studies basically confirming this. So there is a alteration in the gut microbiome in patients with AMD, and this is also true for obesity, where it has been shown that patients have a significantly altered gut microbiome. So in the end, we know that genetics play a role in the development of macular disease, such as nutrition, but we also have found now another link, namely the gut microbiome composition, which plays into this pathogenesis of these macular diseases, whether this is by a direct causality or whether it's by the way we digest food is so far unclear and needs to be further investigated. As conclusion, we can say that the composition of the gut microbiome is altered in patients with neovascular age-related macular degeneration. We're currently undertaking studies in patients with diabetes. The gut microbiome may constitute a link between nutrition and the development of retinal disease, especially diabetic retinopathy. And in the future, targeting of the gut microbiome may be helpful for prevention of metabolic diseases such as atherosclerosis or diabetes and its complications. In the end, I want to thank my collaborators from Switzerland, and I thank you for your attention. I'm happy to take questions.
Thank you, Dr. Martin. For those who have just joined us, Dr. Martin is an associate professor practicing VR surgery in the University of Bern, Switzerland, and he holds a PhD for his studies in ocular immunology and gene therapy. So we are now ready to take questions. I think Professor Kumar Manikvel has one question.
It was a wonderful work. Congratulations. And my question is that did you look at the food habits and lifestyle practices of these people whom you studied?
Yes, so we looked at this. It's to be honest, it's very difficult to really correct our results for that, because if you get the patients in, these are patients attending the clinic. Sometimes it's very hard for them to remember what they ate the week before. But when you look at the literature, the big groups, the genera, they are fairly consistent, even with different food habits. So I think that what I showed before, this should not, or at least when you look at the literature, this should not be influenced by food habits.
I have a question. So we have started talking about acculturation. We are looking for more of this entity in the Singapore studies that are being done. So where they are looking at the migrant Indians who are going and settling in Singapore, and then they have more tendency to have diabetes and consequently retinopathy. So is acculturation is also an entity that involves change in the gut flora?
Yeah, so this has also been shown that if you migrate to other areas, your gut microbiome composition will be altered to a certain extent. So basically, the gut microbiome is influenced by a lot of things, not only nutrition, but also by the way you were delivered. So whether you had a C-section or a normal delivery. So this all influences the composition.
Interesting. Yeah. Any more questions? Thank you, Dr. Martin.
Thank you.
Have you on the seat. Okay, so I'm going to be talking on a global and Indian epidemiology update of diabetic retinopathy. I have no commercial disclosures. So basically, this IC is about epidemiology. This IC is about bedside to bench to bedside. When we are looking in epidemiology, how this helps is, so we study the incidence and prevalence of a disease in a particular area, and we try to note down the risk factors that are there. We take this information, go to the bedside, try to analyze, and then evaluate the possible pathways that can lead to the disease. In our case, it is diabetic retinopathy. Then we try to look at those possible pathways and then try to look at some target molecules or pathway, and we then try to formulate drugs and see how this is going to have its influence on the patient. So we are again taking it to bedside. Now, we have to keep revisiting this schedule, because it's not fixed that once you've moved from bedside to bench and then bedside, that's the end of it. It's not like that. It's a continuous cycle that keeps going on. So once we have the administration of drugs, and then we see how the response is, and if we feel that the response has been inadequate in some people, and then there are outliers, then we go visit those outliers and then try to evaluate those alternative mechanisms. And that is how we have evolved into assessing the phenotypes and the genotypes. And then we have started looking for biomarkers in gene therapies, which the subsequent speakers would be speaking on. And then again, we look into the demographics, and just as Dr. Martin said about acculturation, and then we revisit those things. So this is a continuous cycle, and for clinicians, it is important to understand that seeing patients at bedside doesn't mean that's the end of it. If you have some information that has been unique, you have to pass it on to the researchers, and you yourself can become a researcher in that event, which has happened in my case. So pass on that information, collaborate with a lab person, get on to, then follow it, and then try to see how it changes your practice. Now, coming on to the epidemiological factors. So when we are discussing epidemiology, it is about who has the disease, when they have the disease, and where do they have it. So when we are looking at who, it will be at-risk population, when would cover the risk factors for diabetic retinopathy, and where would be looking at the geographic distribution of the diabetic retinopathy. So when we are talking about diabetic retinopathy, obviously the at-risk population is going to be the diabetic population. So the most common thing that happens in diabetes, the most common risk factor for diabetes leading to diabetic retinopathy is the duration. As all of us are aware that 75% of diabetic patients will eventually turn diabetic, will eventually have retinopathy at 15 to 20 years down the line after diagnosis of the disease. Then also genotype is an upcoming topic in telling that people having a particular pattern of genotype are at risk for diabetes and eventually for diabetic retinopathy. The phenotype is, this is of particular importance for the Indian mention. So we have something which is called as Asian Indian. The morphism is such like they have higher waist circumference, higher levels of total and visceral fat, they have hyperinsulinemia, they have insulin resistance, and a greater predisposition to diabetes as compared to their Caucasian counterparts. Also, something that I have started seeing in practice today is patients who are pre-diabetics. So they are not kept on medication, but then they are kept on regular follow-up. And these pre-diabetics and dysglycemia. So pre-diabetics is having an abnormal glucose tolerance test, and dysglycemia is something having a fluctuating sugar levels. So both these people, apart from diabetics, are predisposed at some part of their life to have retinopathy. So the conversion from pre-diabetics and dysglycemia to diabetics is around 50% over the period of 3 to 4 years. Now coming on to who in diabetics will be at risk for having a severity of diabetic retinopathy. So as again, duration of diabetes is one of the known risk factors. So the longer the duration of diabetes, the more aggressive and more prominent you will have diabetic retinopathy in the eyes. Socioeconomic factors is something that is not seen in the Western country as a risk factors, but yes, of course, when you come to the developing countries like the Southeast Asian countries and the African countries, middle and upper socioeconomic status have been reported to have higher risk of diabetic retinopathy. But even the lower socioeconomic groups, they have diabetic retinopathy. So basically, diabetes is a malnutrition. So the malnutrition can happen either a higher version or the lower version. So what we see in urban slums that we have seen in Mumbai, that in our study we saw that people in the lower socioeconomic group also have diabetic retinopathy. Then acculturation, as already discussed. Then the presence of other systemic conditions like albuminuria. People having a higher version of albuminuria are at 6 times more risk for retinopathy, and so is anemia, which is an important entity when we are looking at the Indian scenario. So people who are anemic have 2 times more risk of developing diabetic retinopathy. Now we come on to the incidences, the pattern in the global and the Indian scenario. Take a look at this graph. So you can see for the incidence patterns before 2000, year 2000, and after 2000, it shows a decline in the incidence pattern. But if you look carefully, there is a decline from the Western thing and the Indian scenario and the Southeast Asian also. But if you look at the absolute numbers of people who are going to have retinopathy, that has increased considerably. So the declining trend may be possibly because people are now getting aware of retinopathy, and also there are concerted public health efforts which are improving to the screening and leading to more people having more treatment. If you look at the annual progression of diabetic retinopathy, the same pattern is being observed here, that you will see a decline in the trends of the incidence and the progression. The same reason, because more and more people are now exposed to the treatment and the screening. For that reason, the incidence is coming down, but again, the absolute number of people that are having diabetes and consequently retinopathy is on an increase. And this is what causes the grave concern for us. If you take a closer look at this chart, you will be seeing that the incidence in the Southeast Asian country is quite higher as compared to Western countries. And if the incidence has been quite high in the African and the Southeast Asian country, and also the onset of proliferative disease is quite higher for people who had retinopathy at the baseline as compared to people who did not have retinopathy at the baseline. So I'm just going to show you about the study that we had done in the urban slum population. So this study was done in the Mumbai, which is home to 45% of the urban slum population. If Mumbai happens to be the financial capital of India, but it has 45% of its population living in slums. So we tried to conduct this study, which was about prevalence and risk factors and the barriers. Just take a look at this video. So these are the slums of Mumbai, very typical with narrow lanes and poor hygiene. These are our community health workers who try to carry out the assessment. So this was the methodology that was followed. And just to mention that the slum population also had a 16.78%, that is quite high percent of diabetic retinopathy amongst the DM, which is quite high. So with this, we're coming towards the end of my presentation. Just a brief mention of role of imaging. So the ratio of an ophthalmologist to the population in India is 1:107,000, which is quite less. And so with the advent of telemedicine, non-mydriatic cameras, and recent AI algorithms, we are trying to penetrate the screening services into the unreachable population so that we get a real idea of what actually the epidemiology of the disease in India is. Just to summarize, the decreasing incidence trends but increasing absolute number of population being affected by diabetes mellitus and consequently suffering with diabetic retinopathy warrants a cohesive approach from the field of medicine and science, and stressing on the translational research evolving from bedside to bedside to bedside. That's all. Thank you.
Thank you, Sunita. So just to introduce Dr. Sunita Mohan, she is actually a veterinary surgeon interested in ocular epidemiology, and she's at the Aditya Hospital in Mumbai. And she was trained there as well as in Madurai Arvind and in Shankara Eye Hospital, Bangalore. Questions, please. So I have a question. So looking at your data and the prevalence of diabetic retinopathy, and these migrants are basically from rural part of India. And in general, the incidence of diabetes as well as retinopathy in rural India is lower than urban India. So these people are first generation migrants, and your data shows that it's similar to the urban Indian population. Why is that you're finding that they have a similar data?
So as just explained by Dr. Zingaragal, that when a person migrates from one place to another, there's a change in the gut microbiome. Also, there are change in dietary habits, the lifestyle that you adopt. And basically, diabetes is a lifestyle disease. So when you're migrating from a place which is full of physical activity to an urban area which is not now as that great in physical activity terms, and also your dietary habits are modifying. So obviously there is a certain physiological change that is going in the body as well, which will probably predispose you to such a condition. And that could be a possible reason that needs to be studied. So that is probably the reason.
Yeah.
Yes.
You mentioned that the incidence is going down. Is that right?
Yes. So the incidence is going down actually. That is what the graph shows. So the incidence is going down probably because people are becoming aware of diabetes and they are taking timely interventions. So the screening of diabetic retinopathy, which is now run on a wider scale by the UK government also. So they have actually started detecting diabetes earlier and started treating them. And also people are becoming aware of diabetes. So this could be a fallacy in two terms, that we are actually trying to look incidence which is coming down from the western population. We have not actually penetrated into the rural and the underserved areas of the Indian scenario. So probably this could be a fallacy that needs to be observed, and probably the imaging is going to help out solve this situation by telling us the actual epidemiology of the disease in the unserved areas, probably.
Very nice presentation. Just one thing, the incidence is reducing, but unfortunately
Absolute
in our
numbers.
in Indian context, if you see, we have only after 2000, and that too only one incidence study.
Yes.
So we cannot really comment in Indian, because as you rightly said, there may be a rise of incidence, or there may be a difference in this in rural and urban. Because even diabetes, it's same, diabetes and pre-diabetes, there are differences in epidemiology in both. So we do expect that probably this is the right time. If some epidemiology study is done to talk about incidence, we can tell that it is reducing.
Yeah, Shankar Nethrala has come up with one. We hope to collaborate and produce a pan-India incidence study. Okay, thank you. I now welcome our next speaker, Professor Kumar Manikwel, who will be talking about understanding the molecular genetics mechanism of DR disease pathology. So, Professor Kumar Manikwel is medical director. He's working on ocular genomics, primarily in gene mapping, mutational screening, and GWAS studies. He has been involved in numerous epidemiological projects across South and Western India and has been also active in genetic counseling, thus practicing bench to bedside. So we now have Professor Kumar Manikwel.
Good morning. And at the outset, I'd like to thank the organizers of the AIOS meeting in Indore for giving me this opportunity, and of course, Dr. Sunita Mohan, the chief instructor. I'd like to thank the co-instructors, Dr. Rajiv Raman, Dr. Professor Kim, Dr. Rajkumar, and Dr. Sev Prasad, and Dr. Zinka Nagel for this opportunity. So I'm going to talk about the molecular genetic mechanisms and how does diabetic retinopathy per se happen in the retina. It's a complicated talk to a clinical audience, so I'll keep it as lay as possible. Now the structure of my talk is this way. So I'll initially talk about the burden, which already has been explained, and then I'll go through rest of my talk in this pattern. So of course everybody knows that there's a huge population of rising people with diabetes and its complications. Retinopathy is one amongst it. In India, China are some of the real epidemic bombs that's ticking and going towards the complications of diabetes. Now, genetic predisposition is an important factor in this whole scenario of diabetic retinopathy. So people with very high hyperglycemia do not get complications, whereas people with very low, well-controlled sugar get complications, and that's because of the genetic predisposition that we have. And 20% of people with diabetes turn to have retinopathy complications, particularly in type 2 diabetes mellitus. It's a huge health economic burden across the world, and even for India, when this paper was published by John Kempen in 2004, said that the direct costs in India would be $2.4 billion, and this is a study which was done almost 15 years ago. And moving on to the molecular mechanisms of diabetic retinopathy, it's a very complicated process, and as you can see here, there are key mechanisms like oxidative stress, inflammation, protein kinase C activation, advanced glycation end products, and polyol pathway. And each of them lead on to various steps of clinical situations, starting from mild inferior to macular edema. And then you find these changes at the tissue level in the retina, the neurovascular unit, starting from microaneurysms and leading on to neovascularization and retinal detachment, and obviously finally leading to vision loss. Now this is exactly what happens in the retina when you have hyperglycemia status, and all the pathways from polyol to hexamen pathway to age, and all of them lead to oxidative stress and then leads to nephropathy, neuropathy, or retinopathy complications in the entire microvascular architecture of the body. I went through some literature and was surprised to see that there are 48 significant pathways that leads on to diabetic retinopathy. Okay, so it's so complicated, and as you saw that Professor Zinka Nagel spoke about gut microbiome, that's emerging and leading to various understanding of how our gut plays a role. And so does our oral and the corneal surface bacteria play a part. Not much is known about it right at this point of time. Now, if you look at mitochondria, this is the most stressed part of the entire system of the cellular environment. And the hyperglycemic state actually leads on to the reactive oxygen species in the mitochondria, which actually triggers apoptotic mechanism with the caspase-3 going up, and then that leads to some of the cell death, neuronal as well as vascular, causing the retinopathy changes. So the reactive oxygen species also causes mutation and DNA damage, DNA damage, which sort of inhibits the autophagy mechanism and then leads to again cell death, apoptotic, and finally retinopathy. So retina is a neurovascular unit. I'm not an ophthalmologist, so you all know this much better than me. But what really triggers the whole process is that the microvascular architecture has fenestra in the arterioles that supplies the retina. And some of these fenestra, or small holes that are there, which are physiological in nature, is covered by the pericytes. So hyperglycemia actually inactivates the pericyte physiological role and makes them to reduce in number and move away from the fenestra, which leads on to the leaks and the bleeding that happens in the retina. So if you can actually stop this process molecularly, then you can actually create a better treatment regimen. So that's the flow from hyperglycemia to the fibrovascular proliferation in the retina that happens. And this is the difference between the normal retina physiological and the one that goes neovascular in nature. And there is a complete imbalance of angiogenesis and angiostatic mechanism in the retina. Now moving on to the next level, this is a study we did in Shankanetralia when I was there, and then we found various genetic factors. For example, glycine 82 sort of makes you susceptible for in-age interaction to get retinopathy, but then if you have serine 82, then that actually protects you. Now, these are some of the genetic factors that we did study and understand in our group when I was in Shankanetralia, multiple factors. But today, the knowledge has exploded, and people have understood the difference between non-proliferative or proliferative diabetic retinopathy genetic factors against the macular edema genetic factors. So that's what this data is showing. And they have found out in GWAS studies that between PDR and the DME, you have huge number of genetic factors that makes people susceptible to get the disease, and that list of the genes that they have identified. There are many genes. It's difficult to go through each one of them. That actually causes the complications in a molecular genetic way and makes a person susceptible. I'm moving on to the animal studies now. From small animal, I'm sure nobody can read this slide, but large animal studies are helping people to identify intervention strategies. As you can see, this is one of the things I explained, which is the pericyte loss that happens in the neurovascular unit of the retina. Now, people are devising many interventional strategies, which could be drug-related plant products, which is what this slide is showing, and also molecular mechanisms by which you can reduce the morbidity of diabetic retinopathy and make people get to a better stage of managing the disease. So the larger picture, this is my last slide, is that there are a lot of genetic and epigenetic mechanisms that takes place in the neuroretina, which leads to DNA damage, and then it breaks the Brooks membrane and then leads on to edema as well as bleeding. And if we can stop this process in some way or delay it, then we can, as I told, can reduce the morbidity. This is the group I work with. Of course, Sunita is a colleague of mine. I'm sorry I've exceeded my time a bit. And finally, thank you.
Any questions? Okay. So we'll take the questions in the end of the sessions then.
Thank you.
I now call upon Dr. S. Rajkumar, speaking on molecular biology of DR. So Dr. S. Rajkumar heads the Genetics and Molecular Biology Lab at Aditya Jyot Foundation, Mumbai. He has carried out projects on human primary lens epithelial cell cultures, and he specializes in evaluating genetics of inherited eye diseases using genomics and transcriptomics approach. So we have Dr. Rajkumar.
Yeah, thank you, Dr. Sunita, and good morning, everyone. At the outset, I would like to thank all the luminaries who accepted our invitation for participating in this IC course, as well as the audience who are presenting over here. And I will be talking on the molecular biology of diabetic retinopathy. So with a special focus to fish out a certain target to design a therapeutics to cure or prevent diabetic retinopathy. So my talk will essentially cover the parasite, role of parasite and vitamin D in the process of diabetic retinopathy. So I believe most of the epidemiological data have been well described by Dr. SM as well as Dr. Kumar Manikavil. And if you take the global scenario, there are about 0.5 billion diabetic mellitus are existing so far. And India, China, Bangladesh and Indonesia, that alone contributes 50% of that number. And almost 35% of that individuals with diabetes are prone to develop diabetic retinopathy. So diabetic retinopathy is a microvascular disease, so that often refers to retinal vascular diseases that damage the vascular blood vessels. So based on the severity and the stage of diabetic retinopathy, it can be classified into two forms: the early non-proliferative diabetic retinopathy and advanced proliferative diabetic retinopathy, that has been characterized by parasite loss, formation of microaneurysms and acellular capillary, whereas the advanced proliferative form can be characterized by vascular leakage and neovascularization. So at any point of time, macular edema can happen. So there are several risk factors have been attributed to diabetic retinopathy, that includes age, gender, lifestyle, gut microbiome, so on so, and systemic infections too. And what are the remedies? Currently there are three different remedies. One is a strict glycemic control, or anti-VEGF therapy, or laser-assisted photocoagulation. However, these therapies are not enough to cure or prevent diabetic retinopathy with 100% precision. So what we need to find out other alternate methodology to find or design a therapeutics. So as Dr. Kumar Manikal have explained about different pathways that are involved in diabetic retinopathy, there are about 48 different pathways. And to simplify that, I have taken that hyperglycemia due to diabetes, that essentially activates half a dozen of pathways, like polyal pathway, inflammatory pathway leads to apoptosis. Then altogether that leads to the loss of pericytes, which is a hallmark of diabetic retinopathy. So the loss of pericytes along with other vascular endothelial hyperplasia that leads to acellularity, then leads to microangiopathy, a condition that is defined as retinopathy. Then with the presence of retinal ischemia and retinal hypoxia, so that leads to neovascularization, ultimately ends with proliferative diabetic retinopathy. So as there are different pathways or multiple number of pathways are involved, and more than 1,000 different molecules are involved. So which pathway or which molecule to be targeted for finding or designing a therapeutics? So that is a 100 time question mark. So considering all these things, so the onset of DR is mainly characterized by early and selective loss of pericytes. So this is a hallmark of diabetic retinopathy. So can we take this as a target? Okay. So when we talk about the pericytes are a specialized contractile mesenchymal cells. It means it has a stem cell progenitor property. So that has a role in angiogenesis, vessel maintenance, as well as in the blood retinal brain formation and function. And when you look into the pericyte with endothelial cell association, the retina is the only tissue having 1:1 ratio, whereas the other macrovascular tissues having about a 1:4 to 1:100. So this number describes the importance of the pericytes. So when this pericyte loss is happening, ultimately it is going to affect the entire system. Okay. So during the diabetes, so in the increase in hyperglycemic condition, that leads to pericyte apoptosis by activating different pathways. So ultimately that ends with pericyte dropout. So this clinically it could be seen as a formation of microaneurysms. So in this picture that you can see, in the presence of hyperglycemia, there is an increase in the ratio of pericytes to ECs. So there are different studies have been performed so far to understand the mechanism of pericyte loss. And one out of that is hyperglycemia induces different pathway. The other one, hyperglycemia induces the migration of the pericytes from one place to other place by activating the ANG-Tie2 pathway. So when we target this pathway, will it be fine? Okay. So now we have to design a strategy to prevent either pericyte loss by regenerating pericytes or restoring the function of the pericytes. How to do that? So the pericytes can be replaced based on its regenerating capacity. So because being a mesenchymal origin, it could be formed as a stem cells and it could be taken further. So this particular article suggests, first in order to make pericyte as a therapeutic target, so the identification of tissue-specific pericyte phenotype and function needs to be performed. The validation and standardization of the methods for pericyte isolation and the establishment of precise pericyte-based therapy can be performed when we perform all in success. And there should be different pericyte sources has to be identified and harvesting pericytes from those sources. And in this particular study, they have performed isolating pericyte from the corneal surgery. So that pericytes have been applied in animal models to cure the retinal eczema. So there could be a successful strategy for pericyte replacement and how to restore the pericyte function. So when I look into the literatures, the vitamin D that has anti-proliferative effect in pericytes and by attenuating the ANG-Tie2 pathway. And by this way, the vitamin D can prevent the migration of pericytes from its origin to others. And vitamin D again, it attenuates pro-angiogenic property of the pericytes. And vitamin D decreases the proliferation and migration of PC and endothelial cells. It causes G0 arrest. An additional clue suggests that pericytes are, it is an anti-neurogenerative property, and it can show, it shows anti-inflammatory property in brain pericytes. So altogether, the vitamin D has some role in restoring the pericyte function. So are we getting enough vitamin D? So what about if we have a insufficiency or deficiency? So the vitamin D data shows, in general, there are about 70 to 100% people are suffering from either deficiency or insufficiency in India as well as in the world. Okay, other studies point out that vitamin D deficiency associated with type 1 mediated diabetic retinopathy and type 2 mediated diabetic retinopathy. And vitamin D uptake is taken up by vitamin D receptors. The vitamin D receptors are found in retinal tissues as well as in the pericytes. So the expression of vitamin D receptor along with vitamin D activates so many pathways and so many genes. So this could be the ideal thing. And vitamin D receptor polymorphism, especially the FOC1 polymorphism, is also associated with diabetic retinopathy. Okay. So in conclusion, emerging evidences suggested a role of vitamin D in pericyte survival and restoration, and vitamin D could be as a potential preventive and therapeutic agent in the management of DR. So the final solution is to solve the DM and the DR. So how to do that? So screening program has to be done. Ophthalmic evaluation for microaneurysms needs to be performed, and finally establishment of methodology for restoration of regeneration of pericytes. And I thank my team. So how to get vitamin D? This is the simplest source of getting vitamin D.
That is so enlightening.
Thank you very much.
Thank you, Dr. Rajkumar. Any questions? Okay, so yeah, we'll have the questions at the end. So may I now call upon Dr. Shobha Prasad, who is our next speaker. She'll be speaking on she'll be speaking on molecular and imaging biomarkers in diabetic retinopathy. Dr. Shobha Prasad is a consultant ophthalmologist from Moorfields Eye Hospital and King's College Hospital, London. She has an active clinical and lab research interest in age-related macular degeneration, diabetic retinopathy, and retinal vascular diseases. Her research areas mainly focus on biomarkers and modeling of retinal morphology in retinal diseases.
Good morning, everybody. So I totally echo my previous speakers that diabetes is a multifactorial disease, and no one molecule can answer our question of trying to prevent or treat diabetic retinopathy. I'm just going to give you an overview of the molecular reports, which are highly controversial at the moment. So the first question we need to think is, why is retina, being an outpouch of the brain, show microvascular changes only in the retina and not in the brain? So as early as 1996, Kern and Engerman did molecular studies in alloxan-induced dogs or galactosemic dogs and found that brain does not have microvascular changes while retina has. So when retina has microaneurysms, loss of pericytes, etc., the brain only shows, vessels only show an increased thickening of the basement membrane. So that's question number one. What is very isolated in the retina that makes it trigger all these responses? Is it because we have photoreceptors in the retina, or is it because we are exposed to light? Is light the stimulus? Or is it the visual cycle which is different? Of course, we don't have it in the brain. Or is it because the retina is relatively avascular and consumes a lot of oxygen? Or is it the retinal pigment epithelium? So as you can see, there are several organs or cellular structures that are different in the retina from the brain, but we do not know which of these structures may be responsible for the differences. Second controversy is dementia is often related to diabetes. In the UK especially, every advertisement says dementia is type 3 diabetes. But why is it related? Is it because the small vessels of the brain suddenly behave like diabetic retinopathy? We already saw from the molecular evaluation that it isn't. So what is it that makes them related? Are the brain changes microvascular, or is it macrovascular disease that we are seeing, example like in stroke and myocardial infarction? We still do not know the answer. There are several reports that show that dementia in diabetes is microvascular, but there are equally number of reports stating it isn't. So at present, we can only show that dementia and diabetes actually share the same risk factors, and maybe especially hypertension, and that may be why they are related. Third thing is, we know that as the previous speakers have mentioned, the retina is a neurovascular bundle. So is the brain. So is many other organs in the body. But we don't know how the nerves and the retina vessels work together. Does neuronal changes occur before retinopathy, or does it occur with retinopathy, or is it a sequelae of vascular changes? So we know from several visual function tests that actually an example here is a multifocal ERG that shows that in diabetes, even before the onset of diabetic retinopathy, you see a delayed implicit time, which progresses as the retinopathy worsens. But if that is the case, the Eurocondo study, which recently published, showed that actually it isn't the case. Diabetic retinopathy patients per se, there are already 3 types in their study. One is there's a group of patients with no retinopathy where there are multifocal ERG changes. There's another group where there is no multifocal changes but vascular changes. And then there's a third group which show coexistent neuronal and vascular changes, again showing us that these patients are not the same. So when we take these patients into clinical trials, this is the biggest disadvantage we have, because we haven't definitely phenotyped our patients very well. The next, we said that the retina consumes a lot of oxygen, and the maximum amount of oxygen consumed is at the photoreceptor layer. And in the dark, we consume more oxygen than in the daytime because of our photoreceptors involved in dark adaptation. So we did the Cleopatra trial, where we thought we could inhibit the dark adaptation at night by giving them a rod suppression lens light of 505 nanometer. But what we found is this light mask does not work. So it does not prevent diabetic retinopathy. And it was very difficult for patients to sleep with this light mask to prevent dark adaptation as well. Tim Kern and Lott have recently published that actually the photoreceptors have high levels of oxidative stress, and perhaps it is that is causing the diabetic retinopathy. This oxidative stress also worsens in the dark. His model suggests that it may be the mitochondria that is causing the trouble, which induces pro-inflammatory reaction and therefore diabetic retinopathy. So he thought 670 nanometer light may in fact prevent diabetic retinopathy, and he showed that applying 670 nanometer light for a few minutes every day can prevent diabetic macular edema, and he showed 4 case reports of that. However, none of us have been able to replicate this to date. Next is the visual cycle. So we think the retina has the visual cycle and therefore it's different. So we have this retinilamine, which is an RPE65 blocker that has been tried in diabetic retinopathy. In small studies, it does show a difference. But again, it hasn't been replicated in larger studies. Or maybe the role of the photoreceptors is by inducing inflammation. And inflammation is the one that triggers diabetic retinopathy. Again, we do not know the direct causal effect as yet. So at present, there are no retinal therapies that have worked to prevent diabetic retinopathy. Ruboxystorin, a protein kinase inhibitor, has been tried. Minocycline has been tried. Retinilamine has been tried. And light mask have been tried. So you can see how we have gone round and round in circles trying to prevent diabetic retinopathy using eye-related structures, eye-related therapies, and none has worked. So we still are back to prevention of diabetes by controlling diabetes, hypertension, and hyperlipidemia. Another controversy is VEGF levels. So we know that anti-VEGF is now the best treatment for diabetic macular edema, but you see that patients without proliferative diabetic retinopathy show very little VEGF levels. And yet, when you give anti-VEGF therapy to people with any form of retinopathy, you see that the diabetic retinopathy disappears or decreases in severity. A very recent study, maybe just months ago, still in progress, shows that intravitreal aflibercept, when given to moderately severe or severe non-proliferative diabetic retinopathy, decreases the rate of retinopathy. So is this our answer? We did the CLARITY study, that is proliferative diabetic retinopathy, for which aflibercept was given. Again, it showed a tremendous effect. But we must remember, when we see a disappearance of new vessels or diabetic retinopathy lesions, it does not mean that the non-perfusion has improved. So that's the controversy. All the retinal features, the vascular features may disappear on a color photograph, but the non-perfusion does not change. So we are yet to understand what is this anti-VEGF doing. It's maybe just preventing the leukostasis and nothing more. We also have another controversy in that when we decrease the central subfield thickness using anti-VEGF effect or any other anti-edema agents, it does not correlate with the visual acuity gained. So you can see huge amount of cystoid macular edema in these cases with varying visual acuities. We believe that maybe the Muller cells, the amount of Muller cells that are available, that may actually help in allowing the vision to transmit through these cellular tissues, but we do not know this and we can't test it. Macular ischemia is another area of big controversy. You can see a large foveal avascular zone with normal vision, and you can see just about a few dropouts causing severe visual acuity loss. DRIL is a new entity called disorganization of the inner retina that seems to be associated with a decrease in visual acuity. So is it actually the neurons in this case appear to be a secondary effect of a vascular change? So in summary, I've given you several controversial reports that do not correlate molecular structures to imaging pathology, but here we are. We have to keep talking, and perhaps in due course we may be able to link them up. Thank you.
Thank you, Dr. Shubha. It was very enlightening talk. Any questions? Yeah, we'll have it at the end.
Okay.
Thank you. So our next speaker is Dr. Rajiv Raman, who would be speaking about next generation screening in diabetic retinopathy, artificial intelligence algorithm for diagnosis and prognostication. Dr. Rajiv Raman is a clinician scientist from Shankar Nethralaya with a vast experience in handling massive epidemiological data. And today he's going to enlighten us by his talk on AI, that is artificial intelligence.
Thank you. It's a real pleasure to be at AIOC 2019 in my home place, and thanks Sunita to invite me for this session, and it's a real pleasure having my mentor Dr. Kumar Manikwel here, who taught the basics of epidemiology when nothing I knew about epidemiology. So next couple of slides I'll be sharing about the next generation screening for diabetic retinopathy, that is artificial intelligence, and AI for DR detection and classification is very much there. It's not a science fiction now. And if you just look into the PubMed articles which have come on AI, we have in 2018 nearly 35 articles on related to AI for diabetic retinopathy were published. The search was AI plus diabetic retinopathy. And this was one of our first papers with Google, where Dr. Kim and me from our Arvind and Shankanetrale along with the Google team had first shown that the deep learning algorithm for diabetic retinopathy works pretty well and with a very high accuracy. This was in November 2016, and it had two editorials by Dr. Neil Bressler and Dr. Tin Wong, and they said two major limitations of this study being that in practice when you screen you don't see only retinopathy, there will be AMD, glaucoma and many other diseases. And the second thing they said that it's only an Indian population, it's not multi-ethnic, and we know that pigmentation is pretty different in every population, so that might be the algorithm may not work. And the next year, the same journal, there was another paper from Dr. Tin Wong and Dr. Shobha Shiv-Prasad also there in this, which looked into deep learning for not only retinopathy but many other diseases and a multi-ethnic population from Singapore. And in April 2018, there was FDA approval for the first AI-based device, the IDEX. I also tried looking at what are the FDA approved algorithms. So we were not the first. There were a lot of approved algorithms, deep learning based algorithm, nearly 8 of them which were approved by FDA before the eye thing came. So it's not only in ophthalmology, but you will see that it's not only, it's in cardiovascular, in brain, CT scan, pathology, this technique has been used. So why deep learning for diabetic retinopathy? And we've heard morning there is a big demand supply mismatch. So we heard yesterday we are 22,000 plus ophthalmologists. If you look at number of diabetics, extrapolation from Ascend Dreams, our epidemiology study, every ophthalmologist has to see nearly 3,500 diabetics if we want to ensure that all diabetics have screening, which is an impossible task. So definitely we need a helping hand, and probably AI can do that. Another good thing about diabetic retinopathy is that there is a very good established grading system, because for generating these algorithms you need something where there is a good classification, and this scale has been in vogue from so many years, which is uniform across the globe. There is also, we know there is inconsistency in grading. So these are 30 ophthalmologists who are grading these set of images, and what you see that what is worrying is even the red that is proliferative, there are a couple of ophthalmologists who have labeled it as moderate or mild diabetic retinopathy. That means that there is very much inconsistency, and probably AI is something which can have a more consistent way of grading diabetic retinopathy. What is deep learning? It's basically a machine learning technique which learns features and tasks directly from a data. Data could be an image, a text or sound. In diabetic retinopathy, it is the retinal image. And what is required is a well-labeled data set. So previous approaches were the feature-based learning, where you need to tell this is microaneurysm, this is a hard exudate, but here in deep learning you need not do that. You need a labeled data set, and then there is something called as a convolutional neural network, and that starts recognizing over a period of time with one set that this is the pathology. Here in this case it is car or some other vehicle. This was our initial work with Indian Institute of Technology in Chennai, where we tried using a feature-based learning, and on some public data set the sensitivity specificity was low. Now WHO has defined that to use any of the tests for screening, it should have a minimum sensitivity specificity more than 80%. So definitely this was not fitting into it. And this is the Google algorithm, which has 26 layers, and it classifies the international grades, the no diabetic retinopathy, mild, moderate, severe and proliferative, tells about the image quality, the left and the right eye, and the field of view. There's just a small video to just demonstrate how this algorithm works. So you just drag the image, and within few seconds, about 10 to 20 seconds, it starts analyzing, and it gives the grades of retinopathy and the grade of diabetic macular edema. And this is how the report from the algorithm comes. And these are the results from our JAMA paper. The sensitivity, specificity, and the AUC was 99% on a set of images, which outperformed ophthalmologist grading. After that, there has been series of algorithms made, and good thing is all of them showed a sensitivity, specificity more than 90%. That means it is a very accurate way of grading diabetic retinopathy. So how this software or this algorithm fits into clinical system is something which is a challenge now, because retinopathy screening practices vary across countries, and it can, some of them are trying to package it with a camera unit. That's one which may be used by a physician, optometrist, or ophthalmologist. Some people are looking at as a centralized reading center. You upload the image and AI starts giving. Or ideally, which I feel would be something which we'll see in a couple of years, would be a point of care device, a hardware which can, a patient himself takes the image and from Google Play download the algorithm and get a diagnosis whether you need a screening. That is patient-based screening. I think that's something which is the future. Now what is more important is a real-time use of this, and what determines is again the accuracy, inaccuracy of the algorithm. What is the ease of integration of this in the existing system, and what is the acceptable miss rate? Because that's something which is a big question, and that will determine how it will come to our clinics. So last 3 years, we have seen more of publications on development and testing in different population, and in these next coming years, we will see a lot of these models for a real-time implementation, how the performance of these algorithms are. This was a video which you had seen yesterday. Just wanted to show again how AI really can change. Okay, 1 minute. Volume.
Google at Verily recognize the importance of screening to address diabetic eye disease, one of the fastest growing causes of preventable blindness in the world. We initiated our work with doctors in India, from Shankar Nethralaya in Chennai and Arvind Eye Care in Madurai. In 2016, we published our first results in JAMA, which clearly showed how AI can very accurately detect DR for retinal images. Last year, we ran field trials at the same institutions, and you will soon see the promising results in the public domain. Google is committed to this fight against blindness due to diabetes, and we look forward to engaging with you as we continue to work together in this important cause.
Thank you very much. I would like to thank my team, Diabetic Retinopathy Research Team at Shankar Nethralaya, for whatever work we have done there. Thank you very much. Any questions, I'll be happy to take. I'd like to invite all of you for the Retina Summit. That's in July 2019 at Shankar Nethralaya. This year, it's all about pediatric retina. Thank you.
Yeah, we'll take a quick question.
Yeah, sometimes when you take the photograph through a camera, through a fundus camera, there are times when one quarter of the retina is not visible very clearly, or it is darkened compared to the, because the type of illumination in the picture varies. So what will you do in that? Because there may be chances then you are totally misdiagnosing in those cases. How this AI is doing the work in those cases?
All these softwares, whether you use a Google, Microsoft, or other software which are available, they do first a grading, whether it is gradable or non-gradable. And as you rightly said, about 30% of the images from a non-mydriatic camera are actually non-gradable. Yes, it improves if you dilate, but the non-gradability is and non-gradability is a referral. So each one have different definitions. Like for the Google one, they do a non-gradability for both DME and DR. Many times you may not be able to tell what is the severity of DR, but the image in the center is a bit clear. You can say whether DME is present or not. So it does a separate grading for both, but yes, that's a concern which is there, and I think the software cannot solve that. It's the hardware.
So do we need to dilate these patients definitely to get a better picture, or do you think in future we can have a non-mediatic cameras also to be able to screen these patients?
There are good. See, it's not the camera fault. The problem is in Indian population, mainly it is the cataract. We actually published this, where we tried looking at how much the non-gradability reduces if you dilate. So it reduces from 30 to 5%. We also looked into what are the factors which are affecting this, and it's the age more than 60 years and vision less than 612 were the two factors which we found on multiple logistic regression. And the reason is cataract. We didn't grade cataract in that, and these are surrogate markers. So it's not the camera fault, it's the population what you are dealing. You are dealing a population more than 40 years. So I don't think any of the camera, even in future, will yes, the quality of images will improve. The newer cameras are much better, but still you will have, like, handheld cameras have little more ungradables as compared to a tabletop model. So there will be always ungradables which will be there, and these are referrals.
Thank you, Dr. Rajiv Raman. I'll take this opportunity to congratulate Dr. Rajiv, Dr. Shobha Prasad, and Dr. Kim for their great work on the artificial intelligence in grading diabetic retinopathy. Our next speaker, Professor Kim Ramaswamy, will be speaking on the newer vistas in diabetic retinopathy imaging. So Professor Kim is from Arvind Eye Hospital, and he is the Chief Medical Officer at the Arvind and responsible for overseeing one of the massive community-based eye care services in India. And he has mentored many of the young vitreoretinal surgeons across India. Professor Kim.
Thank you, Dr. Sunita, for inviting me to this important symposium on diabetic retinopathy, which is of primary interest for me. I have no financial disclosure to make, and it may sound like I'm promoting some of the cameras here, but no, I have no financial interest in any of these. Things have changed, especially in the recent past. We've had a very exciting time with the new cameras, new instruments to look into the retina. Earlier, it was a domain of the anterior segment surgeons, and very little attention was paid to the posterior segment. But with all these newer imaging modalities that have come in, I think things are changing. So I'm just going to touch briefly on few of those that are there and are yet to come. Imaging, of course, the conventional method is the color fundus photography, fundus fluorescein angiography, and in the recent times, the OCT. OCT has evolved with time, from the time domain OCTs to today's swept source OCT. You're seeing it's really surprising to see that we are able to see at the level of every single layer. We talk about 10 layers of the retinal structure, but then we were never able to visualize them. Today, we are able to see them layer by layer and identify the changes that are happening with the OCT. Things totally changed. How you were looking at the macular edema, the ETDRS, fundus pictures were becoming obsolete with all the clinical trials using the OCT as a standard to measure how treatment is being evaluated. So the diabetic macular edema or a vitreomacular traction, which earlier was being treated as just diabetic macular edema, today showed that it needs a surgical intervention. And of course the tractional retinal detachment with different layers being pulled out with intraoperative OCTs, where you're able to know whether you're pulling on the membrane or on the retina is today very much possible. With this OCT, which is all of you are used to, the NFAS visualization came in, where it is based on the software reconstruction of the OCT images, where you're able to see the retinal layers in the coronal plane, where you're able to see how at each layer the structure is maintained, and subsequently the OCTA, that is the optic coherence tomography angiography, came in, and this changed a lot of things for us. From even when the OCT was there, fluorescein angiography was taking a back seat. But with the OCTA, it is really, in many places, it is very little fluorescein is indicated in many of the conditions. So the OCT, it scans the patient's retina with multiple individual A scans, which is compiled into a B scan to provide a cross-sectional structural information of the vessels in various layers. And with FFA, you were able to identify the microaneurysms by the leak, and with the OCT, the OCTA, you were able to identify where these were present, which layer, is it in the deep capillary plexus or the superficial capillary plexus, were all possible with the use of the OCTA. I was seeing that there were more chances of, microaneurysms are present more in the deep capillary plexus than in the superficial capillary plexus. With the identifying the NVA in this structure, where it's very, very subtle, you have to actually do only a fluorescein angiography to identify this NVE, whereas in the OCTA, you are able to look carefully. You will be able to see these structure, the new vessel membrane, and you actually see the extent of the membrane, which gets hidden in the OCTA. Here you will be able to see the coiled new vessel structure. Even if you want to treat on this, you'll be able to see them. It was seen in the studies that the microaneurysm detection rate is still in OCTA was lower than the fluorescein angiography, but the areas of CNP and all this were detected much easier with OCTA. So I won't go to this. Then came the swept source OCT. This made a different, it was like seeing a different picture altogether. Now you were able to see the vitreous, the choroid, any changes that happening. With that, it went of the development of this, when you were able to image the choroid, things changed. They were talking about pachychoroid, you were talking about the different conditions that are affecting, in the CSR, how you were able to find the spectrum of this disease in PCV and various other conditions, even in diabetic retinopathy, how the choroidal changes were being studied. And this made a whole new change with the swept source OCTs. And I just want to touch on this Plex Elite, which is made by Zeiss. This is yet to be in the market, but it's more of a research tool at this point of time, being used in select centers. It's a swept source OCT. It can give an ultra wide 12x12 single shot. It has a very fast image capture time, so even patient blinking or moving causes very little problem to the imaging in these structures. But what is very important to see is how the area is, you're able to see the area, the 12x12, with so much of clarity. And with the Plexielite, you could actually predefine the standard slabs, that is at which layer you want to cut, and see how the cells are structured, either in the deep capillary plexus or in the choriocapillaries. You could make out all the differences. As you can see how the clarity of these blood vessels are in the superficial capillary plexus, that's in the optic nerve head. The other very interesting is the montage, which can combine the multiple 12x12 to get a 70-degree field of view of the fundus with such a beautiful, especially in these capillary plexus. If you had just taken a simple central view, you hardly get anything. You would think it's normal, but with this, you're able to detect the peripheral capillary non-perfusion area. And the high resolution of these images are just phenomenal to find out the vitreous interface, and also those membranes that are pulling on the retina, or the retinal interface with the vitreous. Then came the multimodal imaging. Of course, it is there with using the different techniques, how you are able to arrive at this more useful in conditions like age-related macular degeneration or PCV. But of course, it is combining these modes. It is important that they are mutually registered to make a meaningful decision on this or interpretation of these images. Then came the ultra-wide field fundus photography. Of course, this has changed how we are seeing the fundus with the optos, and the two devices that are there in the market as the optos and the Zeiss Clarus, which again shows, all of you have seen these images where in the peripheral new vessels or peripheral lesions would be missed if you're just looking at the central images of the ETDRS photos. You're likely to see, and today this is becoming much easier for seeing the fundus with a very good almost 200-degree view of the peripheral fundus in these cases. In a case like this, especially the Clarus, which is a true color image, where you don't see any changes in the retina, which appears normal, but when you zoom it in, it doesn't lose any resolution, and you'll be able to find out that there are some hemorrhages or microaneurysms located in this. So zooming in actually helps, and you're able to identify those minute details that you may be missing. So there is an increased identification of diabetic retinopathy in these, and the increased identification of vision-threatening diabetic retinopathy in the different studies when you are comparing with these ultra-wide field fundus photography. Of course, this came the ultra-wide field fluorescein angiography, which showed there was a 3.9 times more non-perfused areas detected when you were doing this wide field, and there was 10% more retinal pathology was seen in these cases. I'll just mention about these adaptive optics. It's enforced visualization at the cellular level. You will be able to see the photoreceptors and the different irregularities that happens in diabetic retinopathy is being studied using adaptive optics, but still it's a research tool. Functional optical coherence tomography has been there for some time, but it's still, some interests are being shown. It's still again an evolving field where we will be able to see many changes or developments in the near future. FLIO, or the fluorescence lifetime imaging ophthalmoscopy of the macular pigment, which describes the different patterns of macular pigment in different diseases. Right now they're studying more in age-related macular degeneration. Very few equipments are there or instruments are there in the market, in the world today, which is again still experimental tool to bring in. But what is important is that this is a very, very exciting period. You see a lot of new imaging devices that are coming in, which will help us to study at the cellular level clinically with non-invasive methods. And as Rajiv pointed out, the role of AI is being studied in interpreting these OCT images, or those subtle changes that the human eye can miss would be picked up using AI over time. So we are in that exciting period. We will have a lot of more devices and algorithms that will be coming in future for us to help the patients much better. Thank you. Thank you again.
Thank you, sir, for a very informative talk. So, any questions to sir? Okay. So I would now request Professor Kim, Dr. Shobha, and Dr. Zinger Nagel to summarize the key points of our IC.
So thank you. I think what I have learned from this IC is that I think first and foremost is that at the moment despite the recent advances in research, there's no preventative treatment, and Soba, you really alluded to that quite well. At the moment, despite the search for novel treatments, there's so far nothing on the horizon, which is quite frustrating, but it really stresses and underlines the need for imaging and early prevention in order to avoid these complications of diabetic retinopathy.
I would stress that I think the gut microbiome will be the way forward, at least as one of the therapeutic areas. I know we obtained quite a lot of information today about genetics in diabetic retinopathy, although a very multifactorial disease. As Dr. Kumar showed, there were tons and pages of genetic genotypes that may be responsible for the disease, but I think our role on perisite, as mentioned, and a plain vitamin D may be our treatment that we may have to pursue in future. I think AI is here to stay, not that because I was an author in one of the paper. I think AI is not only about service evaluation and how we cope with the coming diabetic epidemic, it is more about also learning disease mechanisms through AI. And of course, Dr. Kim mentioned all the new multimodal imaging techniques that's coming our way, and I'm pretty sure we will be diagnosing diabetes more so with images rather than with our slit lamp and biomicroscopy that we were very used to. Thanks.
Thank you. So, I want you to summarize the key points for the imaging, and also because there are a lot of modalities now available for imaging and diagnosing the disease. So, as clinicians, we are limited by resources at times, and at times we have a lot of images, modalities. So, like, how to go about choosing them? Please do stress on those points as well.
Yeah. Before that, I just wanted to mention how, regarding the genetics and the different studies, it's very interesting to see which we have been only looking at the Western literature. Today, we are getting data from our own country. There's a lot of research happening in multiple institutions, which is a big change that's happening in India. And so we will be able to get more data from our own population, which could be much different from the Caucasians or the Western population that will be coming in. So that's a real interesting development that's happening. And regarding the imaging, of course, you buy a new equipment, tomorrow the person will come and say, hey, this is not there in yours and you should be buying. And this with technology, this is bound to happen, just like your own phones, cell phones become obsolete within a month of when you buy it, they change. So today, anything you buy is going to be obsolete within a few months' time, but doesn't mean that everything could be, the things that are coming in could sometimes be a overkill for what your need is. So that's very important to what level of treatment that you're looking at and what level of information that you're looking at for treating your patient is very important for you to understand. And if you're looking at research tools, you're looking at academics, then it's a whole new different ball game. But if you're looking at treating the patients, what's conventional and well-established instruments or equipment is the best to buy at this point of time. I don't know if...
Yeah, Dr. Rajiraman can add on to that.
Yes.
AI.
Really enjoyed every talk of the instruction course, and I think what Dr. Shobha said, it reminded me of one of the talk which recently I heard by Dr. Farooq Udwadia, who is a physician in Mumbai, on forgotten art of medicine, history taking. I think we should not forget that though we have all these newer modalities, we have AI, we have all these tools, still our clinical examination is important. It's good to see those new vessels on a angio-OCT, but you can just do a good slit lamp biomicroscopy 78D and see these vessels. So I think though these can catch, like there are papers on differentiating IRMA from a new vessel, which I feel is not required. If you have a good clinical skill, that's what have been taught to us. I think we should not forget that that's still, though this is yes, genetics and the other exciting, the gut microbiome, this will help us probably identifying people who are at risk, having a more follow-up, a more close follow-up, and newer treatments are in way. So probably we may treat with neuronal damage rather when it goes to a vascular one. Yeah.
Thank you all. I would like to thank the audience for their responses and for their questions and for their attendance as well. May I now request the speakers to be on the stage for a photo, please? And the audience may also join us.